Okay, so I'm excited today. I'm presenting a case to Joseph. I think I've discussed a couple, though last time, I think last weekend it was Seba presenting a case to Joseph. So today I have a case for you, Joseph, and I already have my pen and notebook here to take some proper teaching points from you. This is going to be, I think, not a very long case. So everyone sit tight and learn from Joseph. Yeah, so Joseph, can you see my slide moving?
Yes, I see the introduction.
Yeah, so today we have a 29 years old female presenting with fever. We can start from there.
Yeah, thank you very much, David, for taking your time and preparing this case. And fever is the among the common things we see in hospital. I'm sure every day, if you sit in hospital, you see or hear about fever in your hospital. But before going to the complaint, you look at the patient. This is a 29-year-old female, pretty young, which means very healthy, probably. We'll see in the forthcoming slides. But when they mount fever, it means their immunity is reacting to something. Uh, 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 individual of this age. So every day I say, when you see fever, for me, it's an infection until proven otherwise. And even our approach to fever here, we have a mnemonic, the I med mnemonic, and we say I for infection, M for malignancy, A for autoimmune diseases, D for drugs, and E is for endocrinopathies. But that mnemonic is nothing. The I is everything, first of all. So you have to dwell on the I, go around it, make sure that it is not an infection, probably, which sometimes very hard around here, the way I see it, because we have limited investigations. And then at the end of the day, you say, okay, probably it's not an infection, so maybe it's a malignancy sitting somewhere, maybe a liquid malignancy or solid malignancy, autoimmune diseases. There are a couple of them that can cause fever, SLE and others. Drugs. We have David. I think I discussed it. I presented a case of drug reaction with eosinophilia and systemic syndrome in to David one day, and then endocrinopathies like thyroid storm can cause fever. So going back to the infections, if this patient will be infected, time course is very important. Whether it's acute or chronic, what is the immunostatus, also very, very important. And then the bugs, you all know them, from the viruses to bacteria, um, to the chronic bacterial infections like TB and uh, fungal, etc. So I think without wasting most time, yeah, of another importance. So if you think it's an infection has to come from somewhere. So the port of entry, we all know them. It's either the GI, someone who's diarrhea, or the urinary tract, someone who's painful urination and stuff. Skin and soft tissue, things like cellulitis. Um, some infections, of course, can be coming from outside into the person, like if you have malaria, etc. So let's move on.
Yeah, good start. So here is the short HPI. So this patient presented with a 3 days history of fever. So that was prior to presentation at the hospital. Maybe I should say I saw this patient. I saw the patient first when she was admitted, and other people took over and continued with the patient. So the fever was on and off. It was of no specific periodicity. It was associated with watery, non-bloody diarrhea and some episodes of vomiting. She reports of a dull aching headache, muscle pains, as well as joint pains. But she denied the altered mentation, convulsions, cough, chest pain, abdominal pain, painful urination, skin rash. There were no changes in urinary frequency, no hematuria, no froth urine. So after the 3 days history of fever, fever disappeared as well as the GI symptoms, but then she noted abdominal distension, which was associated with occasional difficulty in breathing. However, she denied palpitations, lower limb swelling, orthopnea P and D. There was no jaundice, no hematemesis or hematochezia, and she denied any dizziness or syncope. And so after the abdominal distension, that is when she decided to present to the hospital. So that's the HPI.
Yeah, thank you very much. That's a nicely taken short history. So, as you're seeing in this patient, I said, okay, it's fever. We assume she's infected unless proven otherwise. That is a later story, unless proven otherwise. Right now, I am assuming this patient is infected. And then, if it's infected, as I said, uh, the acuity of the symptoms very important, and this is an acute illness. You see, it's a 3 days thing. And another very important thing that I think we'll know it later in the past medical history or in the investigations, the immune status of the patient. That would be the second most important thing. So for now, let me assume this is a immunocompetent person with a 3 days history of fever. And then I'm asking, if this is an infection, where is it coming from? That question will be answered by a localizing symptom, as I've talked about them. And you're seeing here some other symptoms like headache, pretty non-specific. This headache of this patient has to be secondary at the end, period. But the muscle and joint pain, I can say these are like myalgias. And myalgias, when you see myalgias, they are inflammatory reaction. They Someone has inflammatory response, they have myalgias. So think of it, if you have had, for example, vaccination as an adult, probably, or even as a kid. Last time I had my COVID vaccine, later you feel myalgia because the inflammatory reaction. So if someone is infected or anything is happening and they have the inflammatory reaction, they will have myalgia. So this is going to the same side that this patient is infected. The fever is the reaction, is the immune response plus headache, myalgias. But the localizing symptoms I'm seeing here, um, I saw, yes, the watery, non-bloody diarrhea, few episodes. So patient is infected. The only localizing symptom I'm seeing here is the GI. So what's a GI infection of this patient? Diarrhea and fever, to me, this will be acute diarrhea. So acute GI infection, which we call gastroenteritis, I believe. And mostly it's usually viral. It's usually viral. Because if this was the story and ending up here and this patient presents to my hospital, I don't have much to do. I can't send their stool for PCR trying to see the bug. I will see it's non-blood diarrhea, acute water diarrhea. Say the patient, this probably is just a viral food poisoning, what we call a viral infection of the GI. Go home, take this maybe some paracetamol, drink plenty of fluid. But David presented another thing. Probably that's what happened initially. And then this patient presented again with another new symptom, which requires more attention than this first one. And that is a distended abdomen. And when an abdomen is distended, you realize some stuff is filling in the abdomen of this lady pretty fast in just 3 days, and then they have a distended abdomen, which I assume is the one which is also causing the occasional DIB. Other things can be there, but a distended abdomen will press will press your you press your muscles of respiration, and then it will be hard for you to respire. So I think that's the case here. So what is the thing that is filling in? It's so unlikely that a solid mass is filling in this patient's abdomen for 3 days. Probably gaseous, but yes, gaseous. This patient is a diarrhea. If the issue was constipation, that would be the case. But with diarrhea, less likely. Um, Another thing that can do that pretty fast is fluid. So maybe what we are talking here is ascites. The chances are very high. And then I'll pause there. But if this turns out to be ascites, patient is starting up with fever, diarrhea. Now they're forming ascites, feeling pretty fast. I'll share my approach of ascites later. But what are the possibilities here? The one that, when you see a patient, David talks here about system one, system two thinking. In system one thinking, minimal GI symptoms followed, minimal GI symptoms, fever, followed by ascites. You think maybe this patient is having a liver issue, is having a liver issue. But you realize, okay, you've seen so many patients with cirrhosis, it's a chronic thing, are the one presenting with ascites. Can an acute liver disease present with the same thing? And the answer is yes. The only chronic stuff that can only present in chronic liver diseases are the hormonal presentations, the gynecomastias, the Kapoor medusa and stuff. But the symptoms that are there because of elevated pressure, pulse pressure, they can be acute. That is well known. So maybe that's one part of it. But I think I should pause here. David present, and then if it's truly what I'm thinking is this ascites to turn out to be ascites, I'll share my approach, which will be about ascites and fever. Thank you.
Okay, thank you. That's amazing. So I hope people are taking notes. So we proceed. The other components of the history were remarkable. So review of systems, nothing remarkable. Past medical history was uncontributory. This patient didn't have any chronic illness. She was not on any medications, no history of surgery, no known allergies. The family social history also was unremarkable. So unless you have anything, I'll go straight to the physical exam.
Yeah. So it's
If you have
yeah.
any comment on those other components of the history.
Yeah, the past medical history is very important here because we told this patient, so we now know she's immunocompetent. She didn't had any chronic illnesses as before. Uh, it's more easier to approach fever in an immunocompetent person than in an immunocompromised patient. Just this week, I had a patient, HIV positive, not taking meds, and then he had fever. Until now, I don't have a diagnosis of the patient, although I referred the patient. But it's so hard, I'm telling you. So let's see the coming slide, David.
Okay, so we go to physical exam. So in general examination, nothing really remarkable. This patient was fully conscious, not pale, not jaundiced. She was not dyspneic. At least she was not using a
Hello? Hello, David. Is it just me or David is gone?
I think he's
Yeah,
gone.
okay.
I can't also hear him.
Uh-huh. I believe he's having some internet issues. Yeah, so I think we'll wait for him to be back. Yeah, for the moment when we're waiting for David, Lauren, what do you think? I should steal your beautiful brain before I proceed.
Uh, Joseph, I'm I'm learning a lot of things from you, from the way you have approached the case. Trying to find out. Okay, so with the presentation of fever, where are these symptoms leading me to? What's wrong with this patient? And I've noted few things which you were speaking about with this fever. Then the primary symptom was fever. Then after some few days, the symptoms subsided to abdominal distension. You are trying now to think, is there ascites? Because if there is ascites, you are trying now to pull out with, well, the liver diseases, are they really involved with this patient? Acute symptoms with presentation of increased portal pressure and later increase in intra-abdominal pressure. You are having some few things to put in here. This patient, a young lady of 29 years old, what probably could be happening to this liver? Am I dealing with viral infections of the liver? The commonest ones, the hepatitis family, the hepatitis B's and C. So the family history and the social history will tell you some of the risk factors. And I think David has not pointed out things like sexual practice for this woman. Is she having multiple sexual partners? What are the possible route of entry if something about her habit or her behavior might lead to to the occurrence of these symptoms? So still I am reading a lot of things, but I think at the end of the day, I truly believe the most affected system is the GI.
Yeah,
So that's the things which I'm trying to learn from you, Joseph, until to this moment.
yeah. I totally agree with you. You are the best, Lauren, because yes, I overlooked that. Yes, when the in the family and social history, that was very important to find out about the risk factor about the infections of the liver. Yeah, that's very nice. Yes, David, I see you. You're back. Ronald was
Yeah. Sorry,
doing some stuff here.
I hope I heard the last part. I'll go back and review the video later to learn that. So my internet shook a little bit, but I'm back. Yeah. So that was about the exam. What was the last part that you heard from me? So I can take it
Yes.
from there.
So I think you presented the general exam, which was normal, right?
Yeah.
So I think we should go for the systemic exam.
Yeah. So in systemic exam, positive findings were in the abdomen, which was distended, moving with respiration. Umbilicus was centrally located, and it was non-tender. Liver, spleen, kidney were not palpable. So there were the central part was tympanic. Peripheries were dull with a positive shifting dullness. Bowel sounds were heard. All other systems, CVS, respiratory, musculoskeletal, as well as neuro, were unremarkable.
Okay. Yeah. So thank you very much.
Yeah, back to you, Joseph.
Yeah. Can you hear me? David, can you hear me?
Yes, I can hear you.
Okay, thank you. Yeah, so as Roland said, and I was thinking initially, chances are this patient is having an ascites, and the shifting dullness here is the most important finding in this patient's exam. So now the problem changes. It's not just fever and diarrhea. Is we put diarrhea with non-specific symptom. The important thing here is this patient is started out with fever.
Sorry, Joseph. I see Brendan is reporting that the voice is breaking.
My voice, or
Is that Joseph or is it mine? I can hear Joseph clearly. I'm not sure about everyone else, and I'm not sure if you hear my voice clearly.
Both of your voices are heard
Your
clearly.
voice is clear.
Okay.
Okay, hope so probably it's Brendan's internet. So can you try and fix that?
Yeah. I love it. So no one wants to be left behind. That's very nice. Internal medicine is the best. Very good. So yeah, I was trying to say the as we hear as the importance, the very important thing about this presentation is you update what you're thinking, which happens as you're seeing patient. So we were presented something and then now it's updated. The new problem is this patient is ascites. That's a problem with fever. So let me share my approach to ascites and try to incorporate infections and see if I can come up with some differential diagnosis. So for me, if you have an ascites, the most valuable way you can approach and arrive at most of the differential diagnosis is to think of the ascites in terms of SAG. Whether you do SAG or not in your hospital, it doesn't matter. It will help you think about these things. So SAG, you just take ascites. It is very easy. It's very easy. Every time I go to any hospital, they say they don't do it. And if you tell them you have the machine, they start doing it. So you take the ascitic fluid, take it to the lab, they measure the albumin, and then you have the albumin in the blood, you minus, you get the answer. If it's above 1.1, that's a transudate. That's a transudate. And then if it's less than 1.1, that's an exudate. So above 1.1, that's a high number, is hypertension. So most is portal hypertension. If it's above 1.1, it's usually a portal hypertension. And then if it's less than 1.1, it's not portal hypertension, it's some inflammatory diseases affecting the peritoneum. So in the exam, I mean, in the investigations, I believe probably David have one of it, which will be very easy. But let's start in terms of thinking about it. If you see above 1.1, think of portal hypertension. Most common cause of portal hypertension is cirrhosis. So make sure that is not cirrhosis. If it is not cirrhosis, then you say non-cirrhotic portal hypertension. There are causes there, including maybe schistosomiasis, including cardiac diseases, including maybe portal vein thrombus, anything inhibiting blood to pass properly through the liver will cause portal hypertension. And then on the other side, which is very more important to patients with fever now, is the inflammatory diseases of the peritoneum. That would be a SAG of less than 1.1. And then here you have inflammation. When we talk of inflammation in AfroDX, just three things: infection, autoimmunity, cancer. A cancer of 3 days, 29 years old, it will be very unlikely. Autoimmune disease, we haven't heard about anything else that this patient has to have an autoimmune disease. There are no joint pain. There are no rash. It's just a few days and then the patient is in here. So maybe less likely also. How about an infection? So an infection to cause inflammation of the peritoneum, to fill your abdomen to the point that you can't breathe normally, has to be a chronic infection. Probably you have seen TB peritonitis, most of you, because you work or studied around in this country. And it's something that builds slowly also. So less likely. So now what are we talking about? We are saying patient has fever, probably they have infection, and then we are saying less likely to have an inflammation of the peritoneum. So we go back, maybe this will be a portal hypertension. So where do we put the fever? Then I'm going back to my system one thinking, I would love to know about the infections that can inflict the liver and cause acute liver injury. And acute liver injury, the portal hypertension can be an acute process. It's possible. The only thing that can't be an acute is those changes that, as I've said, they are hormonal changes that come up with these liver diseases. So I am just right there. And when I think of these infections, because this is immunocompetent lady, I think of hepatitis. And is there another infection? If there is, let me. I don't know, but I think of viral hepatitis. So when we talk about viral hepatitis, usually hepatitis B is the patient in risk of hepatitis B. The answer is yes, because being a Tanzanian, this is 29 years old. Why not? Maybe he's sexually active, and if you're sexually active, you can have it. Or maybe she was born with it, and now what we are seeing is the disease that was there slowly, and just of today we have acute on chronic hepatitis, viral hepatitis B. But again,
Oh, Joseph, your voice is breaking. Is that just my internet?
I don't know.
Oh, can you hear Joseph, everyone?
Yeah, he's starting to, like,
No,
there's an
no,
interruption.
you can't see Joseph.
Yeah,
There's an
Joseph.
interruption.
No. Okay.
Joseph.
Yes, I am talking. You can't hear me? Hello?
Joseph, your voice is breaking.
Can you hear me now? Let me move again to another spot. Problem. How about now?
Now it's coming back. Can you repeat, I think, what you said in the last probably 45 seconds to a minute?
Now you can hear me well, yeah?
Yeah.
Yeah, so I said uh, this to turn out to be an inflammation of the peritoneum is less likely to be this acute. So if we still in that category saying, unless we see the SAG later, if we still in that category saying this will be portal hypertension that can build this fast, but how about the fever? That's why we are thinking of the infections of the liver. And then I was talking about viral hepatitis, so hepatitis B. Patient has risk because she was born here and she lives here. You didn't tell me, but maybe she's sexually active. She's 29. So if you're sexually active, you live in this country, you're at risk of getting hepatitis B unless you're vaccinated, which also we didn't hear in the history. Hepatitis C, probably not so much risk as we saw in the history. Hepatitis A, yes, very likely because of also this how the symptoms started, the non-specific symptom, myalgia, diarrhea, headache, and then fever. So hepatitis A, hepatitis B, acute, very likely in this patient. So I think let's move on.
Okay, thank you, Joseph. So, some more pieces of information that I did not include. This patient is sexually active. She's married in a monogamous relationship, having 2 children, no history of vaccination for hepatitis B. Yeah, so I'll move on to the labs. So here are the labs, and I try to highlight the ones that are abnormal, so you can it can be easier for you to pick them. On CBC, the absolute neutrophil count as well as total WBC count were normal, but monocytes were elevated at 3.1. Hemoglobin was 16, hematocrit 51, MCV, MCH normal. Platelet count was 39. RDT negative, creatinine, BUN, as well as urinalysis were normal. Elevated CRP as well as liver enzymes. The total bilirubin as well as direct were normal. Amylase was normal. I did not, I forgot to highlight the lipase, but was elevated at 108. serum albumin as well as total protein were normal. So as I said, I saw this patient as a first responder, but then I did very few investigations. But during progress in the ward, the physicians who went on with her did some other investigations, including serum ADA, which was elevated at 55, as well as acidic fluid protein elevated at 39, although SAG was not done. That's still an issue. So maybe let's start with these labs and then we can move on from there.
Okay. Yeah.
Back to you, Joseph.
Yeah. Thank you. Thank you very much. Yeah, they're a pretty nice labs. So I'll pick the important one. WBC 9.9 being normal and the diff mono, I'm not doing anything with that. But let's look at the platelets. These are very important in this case because if you have ascites and you have a thrombocytopenia at this level, which is isolated thrombocytopenia, you see the HB and the WBC are within normal limit, and then there is a thrombocytopenia. The likelihood ratio, this is portal hypertension. As I read in this book, I think I shared with David at one point, it's called Symptoms to Diagnosis. You see symptoms, you see some labs, you think what can be the diagnosis. It's like 6. The likelihood is like 6. I memorized that. So in any patient that they have ascites, and then I'm looking at their platelet, they're low, very likely they have a portal hypertension, and what you are seeing, the platelet is low because of blood being pulled in the spleen. So it's sequestered platelets. CRP is telling us something that we already know. This patient is inflamed, that's why they have liver. They are mounting the immune response. So CRP being elevated says this thing, patient is sick, not more than that. ATST, this high, it means transaminitis, there is liver injury. Which doesn't involve the biliary system. So another thing, serum ADA. I don't know about others, but for me, serum ADA doesn't do much in my thinking, unless I'll be struggling to get to get the diagnosis when other aspects of the case are presented. Because serum ADA is being sent to assess for TB, and now you look at the patient. Does the history look like a TB? They say you cannot rule out TB, and I agree with them, but you can say less likely, more likely. At this point, with this serum ADA elevated, I say less likely that we're dealing with a TB with this acute presentation. So I'll just throw away the serum ADA or put in my back, and then if other things come up or what I want to look at is not there, I'll come and take this serum ADA and say, okay, TB can present any way it wants, and then we can say maybe it is. But okay, they did acidic fluid protein, not albumin. That's so unfortunate, but I wonder if I should use acidic fluid protein minus albumin. I don't think that's the case because protein is the total protein. Protein is a combination of albumin and even other proteins which include maybe immunoglobulins. So I'm not going to use that. But for me, even if I don't have serum ADA, this platelet of 39.7, if it was not there, probably it means this is portal hypertension. Another is the transaminitis, liver injury. So what can injure the liver? First is either something that affects the cells of the liver, the hepatocytes, or is something that injures the cell of the biliary tree. But that biliary tree won't be the case because bilirubin is normal here. So this is something that injures the hepatocytes. And there can be infections. We've talked about them: hepatitis B, hepatitis C, hepatitis A, hepatitis D. Drugs drug-induced liver injury. Not likely, because we didn't hear patient is on any kind of drug so far. Another thing will be so infections, drugs, and then autoimmune diseases. As you all know about these things, the primarily biliary cholangitis, or the PBC is called, or the other one is called PSC, primary sclerosing cholangitis. Also, less likely these two present with hyperbilirubinemia, patient are itching a lot. So the one I'm trying to forget, but I shouldn't, is alcohol. Patient is not taking alcohol. So we remain with just probably dealing with infections here. Probably we're dealing with infections. So David, you did hepatitis B. No, I'm not seeing hepatitis B or C. Oh, so there are no hepatitis.
Yeah. So I did not include those ones, but hepatitis B as well as C. So first of all, I didn't even think of them initially, but afterwards they were done, which were negative: hepatitis B surface antigen as well as C antibody. Hepatitis A virus was not done, however.
Hepatitis A was not done. Okay.
Yeah.
Yeah. So if the hepatitis B, hepatitis C were negative, say, is it hepatitis A? Oh, yes, likely. But how about other stuff? Patient is not on any medications, not using any drugs, probably hepatitis A. And then I'll pause there, because because I don't have the SAG. If I had the SAG, they told me this is the exudate, I would have gotten outside of that category of thinking this can be hepatitis infecting the liver and causing portal hypertension. I'll go on the other side and maybe take seriously the other. But for that, I have not much to say. I should listen to the next slide, David.
Yeah, so the next one, the next basically two slides about imaging, and after those, it will be time to commit to a diagnosis. So another one that was done was abdominal pelvic ultrasound, which reported the liver, spleen, kidneys, as well as portal veins were normal. The gallbladder was reported to be, the gallbladder wall was thickened and distended, but no increase in vascularity on Doppler interrogation, and no stones or sludge were seen. And the ultrasound also reported an echoic free fluid in the peritoneal cavity, as well as an echoic free fluid in the pleural cavity, and the right was more than the left. And so they had a conclusion of anechoic cholecystitis that was querying, ascites, moderate ascites, as well as mild bilateral pleural effusion, with the right more than the left. And another imaging, now this was done, so the ultrasound was done during admission. CT scan was done as follow-up in the ward. So the physician who took over said, just to be sure, we have to make sure that we are fully cleared with this patient. So they decided to order an abdominal pelvic CT scan, which reported ascites, and of course, improving the upper parts also reported the mild pleural effusion. Otherwise, it was normal, especially the pelvic part, which the physician was more worried about. There was nothing in the pelvis. So yeah, that's this is where you commit to a diagnosis.
Yeah. Can I see again the ultrasound? Okay. Yeah. So new findings, a different problem, and refinement of the current problem. So all along, I've been thinking about hepatitis, But the most common hepatitis, they were negative, starting to make hepatitis less likely, but didn't rule out hepatitis C, hepatitis A. But I've seen a couple of cases of hepatitis causing liver injury. The liver can be normal, but usually they will tell you something. They write in the report the starry sky appearance of the liver. The liver is shiny. So in this case, the liver is normal, spleen is normal, the kidneys are normal. So one thing will make me change completely my thinking that this is a portal hypertension, and that's a normal spleen. If you have portal hypertension with a platelet of 39, your spleen has to be enlarged because that's the thing that is pulling up the platelets and causing thrombocytopenia. So probably this is not the case of portal hypertension, and I should turn to the other side now, that we are dealing with inflammation of the peritoneum. There is no SAG, but still it will not hinder us from progress in this case. So we are dealing with inflammation of the peritoneum with the evidence we have, and we have ruled out the cause that the thing that can inflict the liver and present with such a picture. So let me dwell in the category that I'm dealing with the inflammation of the peritoneum and see if I can come up with anything. So to me, it's less likely, as I said initially, less likely in just 3 days someone to present with the chronic infection of the peritoneum like a TB, peritonitis, and coming in with these symptoms. This is something that is very, very acute. Or unless maybe another explanation that I will be making up on my own is that the ascites was there slowly, and then what you're seeing now is just the tipping point of what was there even before. But that would be a very bold assumption. Is this the point that we should say, okay, let me think then, if it's not the chronic infections, then what is it? Is there an acute infection that can infect the peritoneum? And again, it's less likely. Maybe I will learn from David that my DDX of acute infections of peritoneum, I don't see anything that is acute up there. So is this the point I should say, okay, we are hearing fever in this case, and all along we are saying infection, because that's the most common thing when people present with fever. Maybe it is not an infection, maybe it's something else. And now, what would that be? Is it a cancer? Again, a cancer of 3 days, 5 days history, less likely. With no any other symptom. Of course, we know cancers of the ovary can present with ascites. I'm not very sure if those patients also have fever. I think less likely again. The cancers with fever usually liquid malignancies. How about an autoimmune disease? Because drugs, less likely. Endocrinopathies, I don't think so. Yeah, so autoimmune disease, probably autoimmune disease. Now, which one will it be among the autoimmune diseases? There is nothing else suggesting this patient has autoimmune disease other than they have an inflamed peritoneum, if that is the case. But the findings in the chest, they're also helpful. It tells us there is also fluid in there. And if someone is keen enough, would have taken the pleural fluid and do Light's criteria again to see exudate, transudate. It also tells you. And then if it would look like an exudate, Then we'll say we're dealing with serositis. Serositis meaning the pleura is being inflamed and then the peritoneum is being inflamed. And when you say serositis, I should send an ANA to look for SLE in this patient. The age is suggestive. David, did you give me the urinalysis? I think not, eh? You're muted. David.
Yeah, I gave you the urinalysis. It was normal.
It was normal.
Lumped among other investigations. Yeah, urinalysis was normal.
Yeah. So again, very very unusual. Maybe very very unusual that the age, the age, the demographic of the patients. They can tell you this can be SLE. Patient is young, female. They can have a SLE, and they're presenting is what they're presenting is serositis. Fever is part of SLE, I understand, but how can I be wrong? I wonder, how can I be wrong in this case? The only way I can be wrong is probably we're dealing with another autoimmune disease that can present the same. I won't have the knowledge to say which one is that. Or again, yeah. Yes, another thing that you told me is the thickened gallbladder. This patient did complain of pain in the right upper quadrant. Again, less likely that that conclusion that the radiologist is coming up with maybe inflammation of the gallbladder without a stone. And you usually see that pretty cases, we don't have to see ascites in those cases. Even if you say it's an inflammation of the gallbladder, yeah, then what? How about what's the thing that can explain the ascites? That will be very difficult again to come up with. So if I was seeing this case and this is the thing that I am getting as the results, I'll send an NA and see, and maybe it's just SLE with serositis. Transaminitis is possible in SLE. SLE can do anything, by the way. Yeah, what else? Yeah, I think I'm out of differential diagnosis, David. I don't know whether you send an ANA or what did you do? No, teachers.
Okay, that's that's an awesome discussion. So I'll tell you how this case resolved. So when I saw this patient, and I think I had a bias toward what seemed to be the final diagnosis, probably because I've had theoretical encounters with the final diagnosis many times. This was the first one that I saw, and when I saw this patient, I didn't look any further. Because just like you, I didn't have many differentials of this patient who presented with a febrile illness, and then in just 3 days, abdominal distension, and what turned out to be ascites. So I didn't have many differentials. So I was biased toward one diagnosis, which turned out to be the final diagnosis. So what was done for this patient was a dengue rapid test, and it turned out to be positive. And so the final diagnosis was dengue with warning signs, or dengue hemorrhagic fever. I'll tell you why I put these two together. And this is the case resolution. So I was on call when I saw this patient. And so when I saw her with all this history, I've supervised the number of sessions for MD5s on viral hemorrhagic fevers, including dengue. And so I've been doing the same sessions for many groups. So in the reading for dengue, you come across that for some patients with dengue, especially that which is categorized as dengue, hemorrhagic fever, or dengue with warning signs, they can present with fluid accumulation in the peritoneum as well as the pleura. And that is because of increased vascular permeability. So you have third spacing of fluid. So when I saw this patient, the febrile illness, which the fever went down, and then the patient presents with abdominal distension. So I say dengue. But then, so when I admitted this patient, of course, I didn't do a lot of investigation. So many of the ones that you see were done by the clinicians in the ward now, who in the particular unit the patient was admitted in, just to be sure. And another one that was done included an echo, just to be sure that there is nothing wrong with the heart. But all the other investigations that were done turned out to be normal. So someone asked about what led to the elevation in the lipase. Of course, I also do not have an explanation, but one thing we know for sure, because of course acute pancreatitis is another thing that can present with ascites. But this patient did not meet criteria for acute pancreatitis because there was no typical abdominal pain, and the pancreatic enzymes, it was the lipase that was elevated, but it was not more than 3 times the upper limit of normal. It was hardly, not even 2 times the upper limit of normal. So I discarded that right away, and it was done later, of course. So this patient, so when I saw her, I thought dengue, so just admitted her because of the thrombocytopenia, which now puts her in the category of dengue with warning signs, or dengue hemorrhagic fever. So it was supportive management that was done in the ward. Ascites improved without intervention, and before discharge, the liver enzymes dropped to less than 100, and I did not. So some of the tests that can be done during physical examination, like tourniquet test, which will tell you this patient is having vascular fragility. In which case, so the tourniquet test, the way it's done is you apply a blood pressure cuff, you measure the patient's blood pressure. So that way you'll determine the systolic as well as diastolic blood pressure. And then afterwards you inflate a blood pressure cuff to a blood pressure which is midway between the systolic and diastolic, and leave it there for 5 minutes. And then after that, you'll observe if this patient develops any petechia. And if the patient develops more than 10 in a 1 inch square area, then we say the tourniquet test is positive, and you see that in dengue because of vascular fragility. So I did not do that because on admission, I wanted to do it, but then, as a clinician, I had my stethoscope, but then I looked for a digital blood pressure cuff unsuccessfully, so I couldn't do it. So yeah, I have a number of teaching points here. I will not teach a lot, but I'll just encourage all of us to go and read about dengue because it's very common, and especially, I believe, for those who are practicing during after these rainy seasons, this month particularly, you see a lot of dengue cases. I saw this patient, I think, a month or two, I think about a month and something ago. So dengue is actually the most common arbovirus infection. So arbovirus is arthropod-borne viruses. They form a big group, and all the viral hemorrhagic fevers you can think of, and some other viruses, including Zika, yellow fever virus, and others, fall in the category of arbovirus. And dengue is the commonest one. So per year, it's reported that it affects more than 400 million people worldwide. But then it's about less than 100 million who will develop symptoms. So majority actually are symptomatic. And it's caused by one of 4 serotypes of dengue. So we have dengue virus 1 all the way to 4. And it's transmitted by mosquitoes, which are Aedes aegypti or Aedes albopictus. The incubation period is anywhere between 3 to 14 days, which means when someone is bitten by an infected mosquito, it takes 3 to 14 days before they develop symptoms. And as I said earlier, majority of the cases are actually asymptomatic. But when they present with symptoms, the presentation is variable from a mild febrile illness all the way to life-threatening shock in a subset of patients, especially the ones who have comorbidities. You talk hypertension, diabetes, pregnant women, the very young and the very old, and any immunocompromising conditions you can think about. And so the clinical presentation, there are 3 phases. We have the febrile phase, the critical phase, and the recovery phase. And there are 2 classification systems, the commonest ones, which are the 1997 WHO classification. So this one classified dengue as dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. And so people challenged this system that it underestimates the burden of disease in dengue, and therefore in 2009 the WHO put forward another classification, and they classified dengue as dengue without warning signs, dengue with warning signs, as well as severe dengue. So I just put it in general there, but I hope everyone will be interested to go and read what goes specifically into these particular categories. Of course, dengue hemorrhagic fever and dengue with warning signs look similar, and severe dengue as well as dengue shock syndrome also look similar. So, for example, this patient presented with fluid accumulation in spaces, including the peritoneum and the pleura. So that is secondary to third spacing of fluid, and that puts the patient in the category of dengue with warning signs or dengue hemorrhagic fever in the previous classification. So when your patient has signs and symptoms which are in keeping with dengue, so that is the way this patient presented: fever, headache, joint as well as muscle pains, and then later on the patient experiences a effervescence, the fever goes down, and the critical phase sets in some patients, and that includes fluid accumulation because of increased vascular permeability. So fluid is pushed into a number of spaces, including the peritoneum and the pleura, and the thrombocytopenia that we saw is also part of dengue with warning signs or dengue hemorrhagic fever. So yeah, when I saw this ascites and the history of fever, straightforward, I thought dengue. I think because of this bias that I've facilitated and read about it a number of times. So that was the closest that I could see that explained the entire patient's presentation. And management of dengue is mainly supportive. So this patient warranted admission because of the warning signs. So warranted admission for supportive treatment, which is mainly hydration, antipyretics, analgesics, and the mainstay is paracetamol. So you should not initiate NSAIDs because they antiplatelet. And remember, this patient had thrombocytopenia. But again, we later on withheld the paracetamol because of the elevated liver enzymes, although of course risk of causing further damage maybe was limited. So yeah, this patient finally improved and stayed in the ward for just a few days for monitoring, and the patient was discharged uneventfully. So yeah, that's what I had, Joseph. Any reflections from you?
Yeah. Reflection is the most important part of any case that we discuss here. And I should, first of all, I'm very thankful that we have these AfroDX sessions here, because yes, I've seen dengue all these months, but I've never even taken my time to read about dengue, because I know, okay, you just come, there is no other infection, we screen you, and you have dengue, supportive management. But I will reflect on 2 things. where it went wrong for me. So one, I don't have the knowledge, because increased vascular permeability to me in dengue is someone with hypotension. So that's not just that. So this case teaches me increased vascular permeability, fluid goes in the empty compartments of the body just inside ascites, pleural effusion. Pretty nice, very nice. And two is I forced the thrombocytopenia to go into my representation, that it has to go along what I'm thinking. It has to go along with the portal hypertension, which turns out as I went on, it's not possible. So the right thing to do was going back and saying, okay, separate these two things. The ultrasound CT shows that this patient doesn't have portal hypertension because the spleen is normal. So discuss the thrombocytopenia on its own. Probably that would have led, who knows, to that this patient is being infected with dengue. But yeah, the hospital that you were in should be thankful, because just seeing and saying this is dengue, oh, that's pretty it. That's shows you're such a good clinician. Very nice. Yeah, thank you very much. Very good case.
Thank you very much, Joseph. You did a terrific job. You're dissecting this case, so I think this underscores the importance of what we are doing here every weekend. Your medicine, the clinical problems that we see many times actually are what are called inverse problems. They are not simple problems or straightforward problems where you just look at now here is cause and here is effect. So many times we start with the effect, and we have so many causes. We try to look among how many causes, which one is the most plausible explanation of the effect that we see. And that's where you see clinicians developing very complex problem-solving skills. So they are like a muscle, and they need to be trained every single time. So that's why we do this, and of course it has served us very well. You see, we've learned a lot of things from Joseph today. You see thrombocytopenia, you see ascites, so many things could be possible. The time course and just a number of other pieces changed the entire story. So that was an incredible job, Joseph. I see a hand from Fabian. Please welcome if you have anything. And anyone else who has something, a question, a comment, please welcome. This is the time.
Yeah, thank you very much for the presentation. It was an eye-opener. From the center where I work right now, I'm actually a resident here at Aga Khan Hospital. We see a lot of dengue patients, and this is one of the most commonest febrile illness we encounter with a lot of patients. So we actually have some experiences, and we have seen different manifestations of dengue fever. So actually, for the first time, I met a patient with pleural effusion, and he was like 35 years old, a male patient with non-comorbid, presented with febrile illnesses, but later on had some shortness of breath. Upon evaluation with chest X-ray, showed pleural effusion. So he was much worried, very much worried, but upon further evaluation, that he's dengue positive. So we did supportive treatment only, and eventually at discharge, the effusion was resolved. And the other presentation, which is very commonest here, is warning signs. Most of the patient comes here with hypotensive, with MAP around less than 50. So we usually admit them in the dependent unit or ICU. Some of them, we support them with inotropes, because their blood pressure, they are very low, and sometimes might cause kidney injury. So this is another very common presentation of this patient with dengue. And some of them, they are very, okay, so actually dengue virus affects two lines. Most patients receive cytopenia, affecting white cell counts and the platelets. Unfortunately, to our patient, the white cells have not been affected, but here we usually see very low white cell counts with eventually significant neutrophilia of even less than 0.5, and these are the patients we isolate them. So this is another commonest manifestation of dengue. Nevertheless, we usually do a serial CBC to usually monitor the progress of our patient, and the most things which we look at is white cell counts every day. With white cell lines, we usually look at hematocrit. So hematocrit is a very good guide for your patient to see if your patient will eventually go to the warning sign, as in when the patient is hemoconcentrated due to vasodilation and leakage of fluid, tends that the hematocrit goes above 45. So hematocrit will give you a good picture about the progression of the disease, and you'll suspect if your patient will go to the warning signs, such as those who might present with ascites due to leakage and third spacing. So hematocrit is another thing that we usually look at in monitoring the progress of the patient with dengue. Yes, so it's a very good case, and whenever we see the patient with thrombocytopenia and probably leukopenia, this diagnosis is one of which we think of and we'll even repeat on the next day so that we can miss. Because we usually look and find what could be the cause. As we see in this case, we usually don't find the real cause, and the diagnosis sometimes is very difficult. So dengue at our setting is very common, especially in Dar es Salaam. So it's one among the common diagnoses that we might consider in a patient presenting with febrile illness. Thank you very much for the case, Dr. David.
Thank you very much, Fabian. That was, thank you for sharing experiences. So I think this is very important. So to learn about cases, you need to see them or hear about them. So I believe everyone who attended these sessions today, when they walk out of here, it's less likely that they will miss a diagnosis of dengue another time. I like someone who has, because I should tell you, just like I said earlier, I've seen a number of dengue cases, but this was my first one to see a patient with dengue presenting with ascites. So it turns out Fabian has seen a number of them, and so we've learned from him today, and I believe every one of us here will be able to make a correct diagnosis next time they see a dengue case. And yeah, I forgot to talk about some findings, especially on ultrasound. So that was initially I couldn't explain it also, but I had to go back to up to date and read again. And turns out, and out of the blue, up to date also mentioned that when you do ultrasonography, a number of patients have been reported with gallbladder wall thickening, although the significance of this is not understood. So the gallbladder wall thickening was also explained by the dengue, because otherwise there was no evidence of no other evidence of cholecystitis, at least clinically, and there were no stones that were seen. So yeah, I see Roland has a hand. Please welcome. Hello, Roland. If you are trying to speak, you are muted.
Yes, thank you, David, and thank you, Joseph, for bringing us this case. Actually, this week we have done a lot of readings about dengue. To begin with, on Wednesday, we had a journal club, and the talk was actually in leukopenia together with some thrombocytopenia in dengue, which are usually the markers of a DWS, which is dengue with warning signs. And one of the things which actually it was very, very important to look about here it was the thrombocytopenia, which I, together with Dr. Joseph, I think at first we are trying to think maybe a GI condition which might explain this, but with the symptoms of fever, then dengue stepping in at such a moment as this, where we are seeing a very high number of patients with dengue in our setup. For example, yesterday I just did ward round, and almost 50% of the patients whom I attended at the ward, they are having dengue. Now, the most important thing which I've actually now to come and add up here, and this is the reason why I raised my hand, is also the part of doing being thorough in doing physical and general examination. Yesterday, we had a patient, 36 years old, with all typical features of dengue, but she had something which was very intriguing, the thrombocytopenia. Also, she had conjunctival hemorrhage, which it was just accidentally discovered. This woman is a student, and she was wearing photochromatic glasses. So by the moment when I was talking with her, when I told her, please, can you remove your glasses? Then this is the moment, like, oh, this is conjunctival hemorrhage. And when we looked to interest back the WBC, there was thrombocytopenia. So we did blood transfusion, and I think she's improving well. Maybe on Monday we're going to discharge her. But one of the very important thing to learn about the dengue with the warning signs or warning symptoms is actually also the part of doing thorough examination. Thank you, Dr. David.
Thank you very much, Roland. So thank you very much, everyone, for joining. I hope we all learned a lot, and I once again request everyone to go open up to date and read about dengue, because you'll see a lot of interesting things there. And I believe because as you've heard, this is the season. Basically, we have a lot of dengue cases. So let's go read about it and improve in our diagnosis. Thank you very much, everyone, for joining. I'm not sure, Joseph, if you have anything.
Good night.
Good night, everyone.